We'll wait for just a minute and then we will kickstart in a minute or so. Welcome to the International Journal Club. This is something that we've been striving for. Thank you Palmedics for the invite. طبعا أهلا وسهلا بكم جميعا في الجورنال كلاب اللي هو عبارة عن النادي البحثي العلمي اللي it will kickstart its program and it will be spreading slowly within the next months. خلال الأشهر القادمة طبعا حيتم عمل ورشات أكبر وحتكون على أرض الواقع and it will be something new and innovative to teach real life research. وهذا طبعا we do these things as we go and as we grow in medicine. Today's, as I previously we've sent the paper. The paper كانت sent beforehand. The way it works, is the students and doctors get the paper. Let's say on this occasion, the endovascular versus open repair abdominal aortic aneurysm, and you'd read it. So you can open it up easily and download it like here and then read the whole article. After you've read the whole article, basically we would huddle, نجتمع كل 2 weeks to discuss that article, simply putting. And of course, discussing that article entitles us إنه نعملها نقد علمي. Slowly we'll get to understand how to do this. طبعا مش من أول مرة, مش من تاني مرة. It will take time and there will be people presenting. There will be students, there will be doctors from various parts of the world, from Palestine, Egypt, Jordan, from here, and everybody will be trying to present and teach as well, so as you go. So let's start off today's. My plan is to do 20 minutes of presenting the paper for those who haven't had a chance to understand or to read it. And then we can have a brief discussion. So it's hoping at a total of 35 minutes. So as you may know, my name is Tamer Nakhal, and I'm currently specializing in vascular surgery in the UK. Today's paper is a paper that is published in the New England Journal of Medicine. So this is the first thing I'd say about, and it was published in 2010. And this is an impact factor of 91, which makes it a very high and prestigious journal. So is an impact of 91 high? Anyone would kind of suggest if it's high or low, and what would be an impact factor at this stage? What do you mean by impact factor? Anyone from the participants? So the impact factor itself is, Khaled?
I'm really not sure, but is it like the amount of times that research has been cited?
Exactly, yes. So it's basically, and simply putting, the amount of, or how many times an average paper that is published in that journal has been published per amount of years. So خلال سنة كم مرة البيبرز فيها بتكون cited. Amazing, yes. So the title is clear. The title is endovascular versus open repair, العملية المفتوحة of abdominal aortic aneurysm. And this is a trial that is done in the UK. I read the paper and I had a system in my mind when I'm critically appraising a paper. As I go, any paper has got an introduction, has got a methodology, and has got result and conclusion and limitations. So my presentation will be the same. And that would be, simply putting, I'll start with the introduction. So the paper talked about options for abdominal aortic aneurysm repair, which included open and endovascular. The 3 principal randomized trials comparing endovascular and open repair of the aortic aneurysm have all shown that there is benefit of endovascular with respect to 30-day mortality. يعني within 30 يوم من عملية endovascular ولا open, endovascular was superior. That's all the randomized control trials has shown before. There is strong evidence that open repair is durable. طبعا open repair, once you open it up, it stays forever. but there has been little careful long-term follow-up of endovascular repair. Like an endovascular repair and stenting, like putting a stent inside, it hasn't been looked at for a longer period of time. يعني بعد ما العيان انعمل له العملية, nobody had looked into it within like 10 years survival, 15 years. So the aim of the study is a UK endovascular aneurysm repair 1, and it's called EVAR-1 trial. Compared the long-term results of endovascular versus open repair in large aneurysms. يعني هي simply putting, it's a long-term study because the short-term showed that endovascular is better. So what is the method that is been used? In this paper, they've used a randomized control trial. Anyone would tell me what level of evidence is this one?
I think the level of evidence of this study is level 1.
Yes, so exactly. So it's level 1. So if you go back to your levels, that's the highest level, which is randomized controlled trial. So the trial was conducted in 37 hospitals that met the criteria, and they trained coordinators to recruit patients and data collect and follow them up. We always have to look at the conflict of interest. لو كان في أي تمويل من أي جهة. The trial was sponsored by the Health Technology Assessment Program of the National Institute of Health and Research in the UK, but there was no private pharmaceutical or medical device company. And this is very important to look at when you are reading, and of course, an article to avoid any conflict of interest bias. Reading through the article, they had inclusion criteria and exclusion criteria. They've included both sexes, so males and females, all who are at least 60 years of age, had a diameter of an aneurysm of 5.5 or more, at least 5.5, patients who were considered to be anatomically and clinically suitable. They excluded anyone who didn't want to have an aneurysm repair, so the patients themselves, those who underwent emergency repair because they have a higher risk of rupture and higher risk of mortality, those in whom the repair was abandoned during surgery. Let's say that surgery was done, but the aorta was left unrepaired, so they couldn't repair it, or those who didn't undergo the randomly assigned procedure. Those patients who were not considered for this trial, they did a separate trial called EVAR-2 trial, and it's published later on. Anyway, so carrying with the methodology, randomly assigned to undergo either open or endovascular. So this is the process what we call randomization. Patients were encouraged to undergo the repair within 1 month after randomization. يعني في خلال شهر كان المفروض يعمل العملية. Although such scheduling was not always possible طبعا لأنه في logistics وفي other reasons, and this also puts an eye بتخليني أفتح عينيا towards how the study was really conducted. Then they did CT, which is الأشعة المقطعية, was performed at 1 month and 3 months in patients undergoing the endovascular repair, and annually in all patients in the 2 study. وبعدك كل سنة. The primary outcome, you have to set an outcome. يعني في نهاية للproject تبعك, their outcome was death from any cause, but aneurysm-related death was also assessed. So they've divided it to subgroups. Death due to any cause, سواء كان يعني أي cause رباني, أي cause due to aneurysm, أي شيء, and death related to graft-specific complications or graft-related reintervention. أحيانا لما نحط الستنت جوا في الاندوفاسكولار بتتحرك, so this stent migration, it needs alignment. أحيانا بيصير اندوليك, so this needs an reintervention. أحيانا الستنت نفسها اللي بتتحط جوا, it blows up, ممكن it increase the sac size and it needs إنه الواحد repair it. أحيانا it goes to infection, so we need to exclude it. Anyway, so looking further into the statistics and how the method was done, طبعا all this I'm just reading for you the article as if you are reading it, and I'm just summarizing it into bullet points, and I always try to follow the 7 by 7, which is 7 lines and 7 words. So they used Stata software, and that was version 10 back then. So this is an older study. They used intention to treat principle with outcomes assessed from the time of randomization. Intention to treat, that means that all patients, يعني كل المرضى who were randomized, اللي عملوا لهم randomization, were included in outcome event, even if they died prior to surgery. يعني أي واحد عمل له randomization, they would put him into the arm. We'll discuss this in a second. They used logistic regression. They used something called Cox regression, Kaplan-Meier estimates, and hazard ratio. Again, I, as a first-time reader, I wouldn't understand all these things. Why did I put them like this? Just to understand a few of those. So today I wanted to learn what is an intention to treat. And I wanted to know what is a Kaplan-Meier estimate. And I wanted to know what is a hazard ratio, because those are important things. Whereas logistics and Cox, I say, oh, this is a bit more advanced for me at this stage. Like, these are tests to compare operative and in-hospital mortality among patients. والكوكس regression تستخدم غالبا في حالات المortality والsurvival rate, and it calculates the rates and reintervention. Kaplan-Meier estimates were used over 8 years. طبعا حنشوف شو يعني Kaplan-Meier in a second, where just over 200 patients remained في الfollow-up. الhazard ratio was calculated. عارفين إنه الhazard هو قديش ناس they had complications due to EVAR على الناس اللي كان عندها complications due to open repair, and they looked at it at 6 months, 6 to 4 years, and then after 4 years. So what is intention to treat? هذا أول سؤال I just gonna ask myself to learn today with yourselves. So intention to treat, if you have a sample size, you randomize them. You randomize them into group A or group B. Group A حيطلع مثلا 100 patients and group B 100 patients. Now these patients, they will be all in your intention to treat, 100. طيب ماشي, السيرجري صارت بعد 1 month. If 15 of them died before surgery, in intention to treat, these 15 will be included in the total mortality. مع إنه ما عملوش surgery, and it will be due to surgery. You see what I mean? So in intention to treat, in this case scenario, there will be 30 people who died in 100 cases, which is 0.3. Now, similarly, if you go to B, those are the other people who were followed up, and they had 15 people who dropped out, another 15. It will be 30 over 100. That's the control group, تمام? And this is the group who underwent surgery. فلما تيجي تعمل relative risk, which should be divided by each other, it shows that actually the relative risk is 1 and the ratio is 0, which is no effect, which is true, which is actually untrue in a way or another. ليش؟ لأنه there are 15 people who were added on prior to surgery because of intention to treat. That's why it would be better to do it as per protocol. And this is the other thing that we need to learn. And I learned it with you today, which means that we actually take the actual mortality due to the surgery itself, which is actually 15 here instead, and divided by the total. And then you find out that the relative risk actually is high, and that apparently is an effect. Yes? So again, in area A, just always think, when you are thinking about randomization, think, is it intention to treat or is it as per protocol? So these are the baseline characteristics of the patient, some demographics. Why do we need to look at these? So to look at these, to make sure that both groups were close or relatively close to each other. The endovascular repair versus the open repair, the age, they were similar, so cannot tell if the same for females in terms of male percentage. لأنه most of the study was males, 90% who had EVAR and 91% who were open repair, and only 10% were females. So this study might not be the best study to generalize the outcomes for females, like, and it would be better to generalize it than males. If you look at all the other parameters, they're relatively close to each other. يعني the two groups were very similar. And they used في أغلب الأحيان الميديان والinterquartile range, which is sensible. ليش؟ لأنه الداتا is skewed. Skewed يعني منحرفة. If you looked at the videos on statistics that have previously been published, that means that it's a correct test to use in here. So steps in thinking, is this a good research or not? I always ask, are the results valid? Which means, were they randomized? Is it concealed? Did the patients know about where they are going for which procedure? Group similarity, which we looked at and it was similar. Intention to treat or as per protocol. What are the results with sample size? And will they help me in care for my patients? يعني هل هذه الورقة البحثية حتضيف لي إشي لحياتي العملية ولا لا? Is it clinically important? Let's look together at the results quickly. So it was done during a period of this 1999 to 2004. They included a big amount of patients. They were all equally and randomly divided into two groups. Overall, لاحظ انه في 1082 patients, and they've added 170 later on. Patients were followed up for a minimum of 5 years and a maximum of 10 years, and a median follow-up, and it's a good test to use, median and not mean, until death or end of study was 6 years. So this was their primary outcome. Only 1% of patients were lost, which is a good actually percentage. So operative mortality, 30 days after surgery, a number of patients who had died was 11, 1.8 في endovascular, و4.3 in the open repair, which means in looking at this, you would say, oh, endovascular is much better to do. Well, in survival analysis, we need to use hazard ratio. Again, I've learned something new. What is a hazard ratio? It's a measure of an effect or an intervention on an outcome of interest over time, but it has to be a specific time. Reported in time to event analysis, يعني امتى حصل بالضبط, and what's the hazard of it happening at this stage. يعني عامل الخطر. يعني how long a particular event takes place to happen. في الإيفنت اللي هنا اللي كنا ندور عليه هو mortality, death due to either surgery or either due to an EVAR. So looking at here, they looked at a total mortality, and they used this Cox regression, which we would need to read together later on at some stage. And they stratified the patients into up to 6 months, 6 to 4 years, and 4 years. And they looked and compared endovascular to open, and then they analyzed it with hazard ratio. And then they looked at, is the hazard ratio significant using a p-value? Again, you can see here that it is very kind of similar, and it's insignificant in most of the cases. يعني حتى هنا طلع endovascular 26 من 600 شخص, هنا 45 من 600 شخص. You'd think, oh my God, here it's 8 and here's 15. Is it significant? They calculated the hazard ratio, which is 0.61, and that is actually insignificant. When would you think that the value is significant? When is the p-value significant? Anyone knows?
I think it's less than 0.05.
Yeah, so simply putting, if it's less than 5% or 0.05, then, and this is a set that you would think about if the confidence interval is 95%. Great. So time since randomization. بعد هيك تطلع على patients as a long term. لاحظوا على long term since randomization aneurysm related death. This was all death, يعني حتى لو مات due to MI, مات due to anything, but this is aneurysm related death. لاحظوا إنه it becomes different. We look at the p-value and you can find that this is significant and this is significant. Look at the hazard ratio, it's also significant. And you look at the open versus endovascular and becomes significant here that you have actually more endovascular people who died more after 4 years due to aneurysm related death. And it is significant in this case. Yeah. So again, looking at the overall, this is called a survival analysis, أو بيسموها Kaplan-Meier estimate. What they look at the y and x-axis, first they look at the percentage surviving. All samples start as 100%. كل العينات بتبدأ 100%. And we follow them over years. Here they followed them up to 8 years. And if you look at the trend, you will have people dying, isn't it? So those people who die, they will come down. So here, for example, it's almost reached 50%. So half of the patients almost died after 8 years. But this is due to all-cause mortality, يعني any cause. لأنه شايفين هاي it's the same, open or endovascular. Like in looking at aneurysm-related survival, it's fairly the same. But then if you look at the endovascular, it catches up with the open repair. So at the beginning, endovascular looks like it's better, but then it catches up with the open repair on the long term. Anyway, so I wanted kind of to elaborate more on this. So this is another Kaplan-Meier estimate, and this is the survival rate So without a complication. So this is for complication. الأول كان على mortality. 100% had the operation, and then we followed them up for 8 years. الأوبن ما كانش لهم كتير complications. يعني more than 75% didn't have complications. لكن look at the EVAR. A lot of them had complications. Almost 50% within 8 years had complication. Similarly here, if you look at the re-intervention, يعني كم مرة اضطرينا ناخد العيان تاني للعمليات أو اضطرينا إنه نعمل حاجة بالستنت نضيف لها إشي أو نعملها embolization أو حاجة زي هيك. So we started with 100%. We followed all the patients لمدة 8 سنين. لقينا الopen repair stays almost the same, isn't it? More than 90%. Whereas the endovascular starts to drop. يعني they needed more and more intervention as time goes by. Yeah, so again, it's below 75. So in summary, I know this is a very crowded slide, but the results are that median follow-up confirmed that operative mortality associated with endovascular was only a third of that associated with open. يعني على short term, the endovascular is better. Aneurysm-related mortality was reduced during the early years after endovascular. لكن ال early year benefit was completely lost في long term. يعني الاندوفاسكولار بعد هيك فقدت البنفيت هذا وأصبح actually it's higher aneurysm mortality after 4 years. So the open repair would be better for longer term outcome. No significant difference في total mortality, where rate of graft related complications after endovascular repair remains substantial. Secondary rupture after aneurysm repair was reported only after endovascular. ليش? You'd expect this, and the stent is metallic, and metal can expand, and they have, they call it buds, they hooks, and these hooks sometimes cannot يعني align مع الارتري كويس, فبالتالي حتلاقي البلد is coming from the sides, فthen the stent can rupture. لكن الopen repair, it's a hand sewn, بتخيطها بإيدك, and it's more durable. So that's why all the patients who had long-term rupture, they were actually EVAR. Therefore, the loss of aneurysm-related survival benefit in endovascular repair group would appear to be attributable principally to endograft rupture. ليش؟ هذا هو السبب الرئيسي اللي خلى الإيفار يخسر في الكومبيتيشن هنا أو في الكومباريزون إنه they can rupture, whereas open repair doesn't. They commented on their limitations. The limitation was first the endografts. طبعا هم هناك استخدموا second with third generation endografts. Now there are much more improved endografts with choices. لكن still durability is debatable. The standardization, as I stated, they used patients to standardize them. لكن they didn't have a standard أول 3 سنين. Thus, a reported complication reflected the assessment made by the radiologist. يعني كل الاسسمنتس تبعت الرابتشر تبعت الانيوريزم او شو اللي صار بالفولو اب كان dependent on the radiologist, and that can cause bias طبعا. بعد 3 سنين عملوا standardization and they've published it. ومن بعد 3 سنين صار في standardization, لكن اول 3 سنين كان في خلل في standardization. بعدين they didn't record the outpatient procedure. ما حكوش كم واحد منهم طلبوا منهم diagnostic angiography, كم واحد عملوا repair بعديها obtain more detailed information. The corresponding underestimation of reintervention rate and cost have occurred for the open since readmission data were not collected. ما فيش حد عمل collection للreadmission تبعون البيشنتس بعد ما طلعوا من المستشفى واضطروا يرجعوا تاني عشان complications. So there is a few limitations, but overall, I think that the paper is a very strong paper. So in conclusion, the endovascular procedure was associated with significant lower mortality operatively. No significant difference were seen in total mortality or aneurysm-related mortality, while endovascular repair was associated with increased rates of complications and reintervention and was more costly. وطبعا I haven't put it into the slides, but they've calculated the whole cost. والإيفر طبعا الستنتس أغلى بكتير من الأوبن repair. So what will I kind of take from this for my practice? إنه if I have a patient who is, let's say, 90 years of age, and another patient who is, let's say, 60 years of age, then I will take the 60 years of age for an open repair if he's fit for it. ليش؟ لأن الديورابيلتي تبعته حتكون أحسن، فالcomplications أكتر يعني أقل في الأوبن. Whereas patients who are, let's say, 90 years of age, they're not that fit, and their يعني mortality estimate أو their survival حيكون إيش 5 سنين 10 سنين, then I would take them for EVAR. And this is how a paper has impacted my practice when I think about the patient. Of course, always I give the options to the patients, and they would tell me what they would like to do and how to proceed. So now we can have a bit of discussion. I presume that some people read the article. They might have found some similarities, differences, or they have something to add and comment, even on the Kaplan-Meiers or any of those. Anyone that's got anything to discuss about this paper? From a critically kind of critique of it. So I can add on a few things as well. Never be deceived by Kaplan-Meier. يعني Kaplan-Meier survival rate ما تطلعوش إنه there is a huge drop that means automatically that is significant. No, that means actually that we need to do a p-value. So if you have any further suggestions or comments, please type it in here. Meanwhile, for next time, it will be somebody else who will be presenting similarly. As you have seen, this is how we critically appraise a paper. And ideally, we would sit down and drink coffee or something and critically think about the paper. Was it done properly? What was not done properly in the study, etc. And this will come with time. The more papers we start doing it together, the more confident you become at basically critiquing it. So for example, here I learned what is a hazard ratio and how it is calculated. So after reading this paper, I think this is something that we need to take home for our statistics. I learned also what is validity of a study. So it's randomized, it's concealed, ما كانش عيانين عارفين, group similarities, and I understood what is intention to treat versus per protocol. Then I looked up at what is the significant, and I looked up at the median. And again, that helped me out in understanding what are the baseline characteristics. And then I brought this as an example for what is the difference between intention to treat and how it can impact your results. And then I think if I would do something, I'd read more about logistic regression and Cox regression and understand them much more better next time. Looking at the exclusion-inclusion criteria, they were quite fair. Sometimes here I think, looking at now, because I'm doing some studies about female AAAs, maybe they should have repaired it in females at an earlier stage, because there is a lot of studies saying that females should have at least 5 centimeters aortic repair. So this is another thing, to look at. And it's a randomized, and there was no conflict of interest. And I've given you an introduction about, the whole kind of what it is, so that people understand what's an aortic graft. And this is a picture, a 3D reconstruction of the aortic graft, as you can see. And that why we consider the death of patients who died before doing surgery. Yes, so again, in intention to treat, the assumption is that you have randomized them. And because you want to avoid bias and you want to avoid wrongly stratifying patients, يعني ما بدكش تقول للعيان اسمع انتوا روحوا endovascular وانتوا روحوا open. لا خلاص, you have a system, and the system basically says that these 100 have to go for this procedure. مهما يحصل, this is their assignment number. خلاص هذا هو رقمهم. ماتوا due to procedure, not due to procedure, that's not their business. المهم انه يكون fairness في randomization. And this is basically to avoid absolute bias. لكن that's why you have the problem then, that patients who didn't undergo surgery and died before surgery, they would be counted towards it. And this would be part of the limitations. So that's a good question, actually. And that's why you sometimes need to do it as per protocol and stratify it here, as I've shown before. So something called a true and untrue effect. I think for this level, it's good to know what is the difference, and that's it. Any further discussions about it? Great. So I think that
Doctor, when you make an open surgery for a patient, did you ask him about any other problems like heart attack or any other problem make the open surgery worse than endovascular?
Yeah, so that's again a very good point. They haven't actually specified much of the preoperative assessment in here. They talked about the body mass index, the diabetes, smoking, a history of cardiac disease, which is written here, and blood pressure. They didn't wrote, for example, the ASA score for them, how frail they were. And, you know, presuming that 74 years of age are quite young, because I see most of the AAA patients are actually quite older. So yeah, that's a good question, actually. It's valid. We need to look into that in further details and how they preoperatively have assessed that. About details, to put a lot of details, even important ones, in supplementary material, and do not write in there. Yes, so again here, Muhammad, I think the trial itself, as you can see from the page itself, it's only 9 pages, which is the most important things. And you can always add an appendix. So for example, there's a lot of tables that are not included in the paper, but they're very important, absolutely important, especially in randomizations and how they trained all the people from 37 different, centers to do the same job. So this all goes and counts into the thing. You're right. Any other questions? I think that was a very good discussion as a very first time doing a journal club. Thank you everyone for participating. Next time there will be somebody else who will be presenting, hoping at slowly we get to know how to critique a paper, how to be systematic. We'll develop our own way of critiquing a paper. So يعني لازم يكون في system معين. As you may see, I said this is a very good paper from a very high impact journal, and it's a trial, so level 1 evidence. Yes, it's slightly old. It's been almost 11 years old, but it's worth starting it and understanding it. Again, thank you very much everyone for attending, and thank you for Palmedics for hosting me today. And all the doctors from the UK who attended today's session, and from other countries as well.